This video will concentrate on the femoral approach for central line catheterization. Femoral venous cannulation is generally accepted as a less favoured site for ICU patients due to concerns about increased infection rates, lower limb DVT risk, lower patient comfort, and practicality of impaired flow when the hip is flexed. These concerns are magnified in the morbidly obese. Despite these concerns, the femoral route may be favoured as an accessible, compressible, and acutely safe site, especially in emergent situations. Patient position can be challenging. Ideally, the hip should be slightly abducted and brought anteriorly, often with a pillow placed behind the buttock contralateral to the insertion site, with the patient lying flat. It is important to appreciate the anatomy of the common femoral vein as it becomes more superficial in the femoral triangle prior to passing under the inguinal ligament to become the external iliac vein in the pelvis. The femoral triangle is bordered superiorly by the inguinal ligament, medially by the adductor longus muscle, and laterally by the sartorius muscle. The femoral vein is contained in the femoral sheath, where it usually lies medial to the femoral artery. The inguinal ligament runs from the pubic tubercle to the anterior superior iliac spine. Identify the midpoint of these two surface bony landmarks to ascertain the position just lateral to the femoral artery. Careful palpation should allow more precise identification of the femoral artery, with the vein generally lying about 1 centimetre medial to this. Ultrasound has been shown to improve first-pass success in femoral venous puncture to about 90 to 95% from 60% using the landmark technique alone, as well as a lower rate of inadvertent arterial puncture. This is likely due to anatomical variations to the traditionally expected femoral anatomy just described. Distinguishing the artery from the vein on ultrasound is similar to other modalities, with the vein being larger and more compressible. A more detailed explanation of the use of ultrasound in central venous cannulation is found in a separate video. The following are site-specific instructions for the femoral approach. The desired insertion point is 2 to 3 centimetres below the inguinal ligament, with the needle inserted at approximately 45 degrees to the skin, aiming to enter the vein well before it traverses under the ligament and becomes both incompressible and closely involved with the abdominal contents. Ensure the CVL is inserted to the hub prior to aspirating and flushing all lumens. Secure, cover, and document as already described. In summary, the femoral approach has the following advantages and limitations. Advantages include speed and success in resuscitation situations, and lack of risk to supradiaphragmatic structures. Limitations include practical difficulty in the obese, increased infection rates, especially those who are overweight, DVT risk, and the inability of the patient to be mobilised, the latter being a significant problem in the ICU. In the case of renal replacement therapy, catheter kinking when semi-recumbent may significantly impair flow rates, reduce filter life, and therefore make this route suboptimal.